East. Professor Fadi Jara, he's a friend of mine. I'm honored to be friend with him. He's a professor and chairman of Department of Radiation Therapy, American University of Beirut. He's the founding director of the Naif Basil Cancer Institute in 2007-2012. He will be talking about radiotherapy in CA pancreas. In esophageal cancer.
Thank you, Yusri. Very nice for the presentation, for the introduction, and thank you for Hisham and all the organizers for the invitation. It's always a pleasure to be here at this fantastic city and this fantastic place. My task today is to talk on radiotherapy techniques for esophageal cancer, but be assured I will not bore you with imaging and techniques of radiation technology. I will just give you some background on the usage of radiation in esophageal cancer to explain how we are doing it and what is the place of radiation therapy in esophageal cancer during this 15-minute talk. So I will be discussing the value of chemoradiation therapy in unresectable esophageal cancer. I will mention on the dose response and toxicity for radiation therapy and what we can do about it. And then I will close on the comparison between 3D radiation therapy and IMRT for the benefit of patients treated for esophageal cancer. A brief review of the facts. The incidence of esophageal cancer seems to idle around 17,000 new cases in the US. This has been the case for the past few years. But I want you to look at these numbers. 35% of patients will present with distant metastasis, and many of them will present with unresectable status. For those patients who are unresectable, we offer chemoradiation as definitive therapy. And for patients who have localized disease and are resectable, they are candidate for the neoadjuvant component of the treatment, which is also chemoradiation. Chemoradiation is the standard of care for unresectable patients, as I said. It is superior to radiation therapy only. We have known this since the 70s with the famous RTOG trials that were published repeatedly between 92 and 99. And this is a graphic presentation where for the first time the value of chemoradiation in unresectable esophageal cancer was shown, and with about 30%, between 25 to 30% overall survival, which was a big change at the time in favor of a non-surgical therapy for esophageal cancer. Now, the other part of the treatment is when we use neoadjuvant chemoradiation for resectable esophageal cancer, and we have evidence that neoadjuvant chemoradiation followed by surgery is superior to surgery alone for resectable patients. And here we have the meta-analysis published by Gebski and colleagues, originally in 2007 and updated in 2011, including 17 trials, 1,854 patients, where they showed in those trials the pathologic CR after neoadjuvant chemoradiation ranging between 16 to 40%, with 22% survival advantage provided by the addition of chemoradiation before surgery. No difference between squamous and adenocarcinoma. This is just to remind you of the facts, not to discuss it in length. But obviously most of you and all of us know and are familiar with the CROSS trial, which was published in 2012 after the meta-analysis, where everybody now knows that this trial has been very publicized and showed that chemoradiation before surgery is superior to surgery alone. And this CROSS trial scheme is now being used across the globe by many teams. Now, having said that, we know also that the use of chemoradiation alone or without surgery has been associated with a decrease in local regional control. This is another meta-analysis published in 2012 where the authors have shown in several trials whenever chemoradiation is used alone, there is a decrease in local regional control. And we know this. We have always seen in many studies where we add surgery, we improve local region control. We increase complications, we know that, but we also improve local region control. And this is evidenced here by this meta-analysis. So what does that mean? This means that maybe the chemoradiation that we are providing is not optimal and needs to be improved. The drugs needs to be improved, and possibly the radiation part, the technique and the doses should be improved to improve local region control. Now, this has been tested in the past, and this is it's a negative study that many of you probably familiar with. This is the RTOG 9405, published by Bruce Minsky more than 10 years ago from the RTOG, where they tested 64 gray versus 50 gray with the standard 5-FU and cisplatin. And this was not, unfortunately, to the expected level, and the patients who received the higher dose had the lower survival. Many of you who are familiar with this study know that the loss of survival was actually not directly related to the dosing, but still those patients did not really do better, and they did actually worse, and the study was stopped, and nobody now has revisited this high dose component of the chemoradiation because of the fear of having this problem. Now, having said that, this trial was done at the time when 2D radiation therapy was practiced, and no 3D and no IMRT was available at the time. So many people can argue now that with the newer technologies we have, this might not happen, and we could probably provide higher doses of chemoradiation or radiation without this excess of mortality. Now, how we do that? This is a comparison of 3D. This is a 3D, a crossfire, where you have the high dose in the center, and you still have a incidental dose of radiation at the ports of entry. This is a 3D. This is IMRT using an arc therapy, where you can see that the hot spot or the concentrated dose is right where the tumor is, but at the expense of dispersing dosing of radiation along the heart and more importantly, the lungs. So this is very important to keep in mind. We concentrate the dose, but also we disperse the low dose volume along the lungs, and many people don't like that. And this is the protons, the famous protons, the very expensive technology. It's basically providing a high dose with very, very low dose to the non-entry zones of the body. You have here an incidental dose of radiation from the back and from the side, but the heart and the liver and the lung could be spared. Obviously, protons would be attractive, but this is under investigation and it's not available everywhere. I will concentrate on the 3D versus IMRT for the talk. Now, how we do it? We have to construct our gross tumor volume from CT scans, and I insist on CT scans, not always PET, because sometimes CT scans can show you things that PET cannot tell you because of the size. PET-CT, obviously, we add this information, endoscopy, EUS, anything that could help to construct the gross tumor volume is important to include. We add 4 centimeter margin above and below, and this is the RTOG recommendation. This is what most people do. We add 1 centimeter radial margin, and for patients who have esophageal tumor in the cervical esophagus, we add the supraclavicular lymph nodes, and for those who are in the lower esophagus, we add the celiac lymph nodes, even if those that were not involved. And obviously, we use, as I showed you, 3D IMRT, or better, arc therapy or volumetric optimization, which is called VMAT or rapid arc, whatever you want to call it. Now, this is a one slide to show you the comparison between, again, the 3D IMRT and VMAT, or which is arc modulation. This is the 3D. I want you to concentrate. The green is the target, and I want you to concentrate. I don't know if you can see it from the back. The low dose, the green here, which is a low dose, which is what we call the incidental low dose of radiation, and the intermediate dose. In the 3D, the low dose is not very scattered, and you can see that the low dose are actually very tightly related to the tumor, which is the only advantage of the 3D. But if you see the intermediate dose, and here this is for the lung, but intermediate dose is actually traversing the entire mediastinum, including the heart, and this is very bad. Now, the IMRT can do better. You can see that the intermediate dose is kind of like compressed a little bit, but the low dose is dispersed a little bit more on the lung. And when you use the volumetric optimization, you have the intermediate dose is compressed even more. You can see it more here in this sagittal view, and the low dose again is more dispersed. So the advantage of this is you can have the concentrated dose at the level of the primary. The intermediate is not as dispersed as wide, at the expense, again, of low dose being more dispersed. And this has relevance, and I will show you in a minute why. Now, the MD Anderson have really done quite a good job by collecting their retrospectively their 676 patients treated by either 3D, 413 patients, or IMRT, and I used propensity score analysis to compare overall survival, local failure, and distant metastasis. And this is a very important piece of information that I will share with you. The first slide here shows that there was an improvement of overall survival for the benefit of IMRT. These curves have the confidence interval with them, that's why they look a little bit crowded. But look, red is IMRT, 3D is black. And local regional control is improved by the use of IMRT because you have better imaging, better targeting and more concentration probably of the, or better imaging control. Now, however, cancer-specific mortality was not affected because mainly, probably because of those patients die mainly of distant metastasis, and distant metastases were not affected, obviously, by the technique. So local regional control has been improved. However, cancer-specific mortality in this particular study was not improved. Now, the improvement of mortality of overall survival probably came from the change of pattern of cause of death. This is the cause of death for the entire population. Cancer deaths in red, and here at the bottom from pulmonary, cardiac, or other unknown causes of death. And when we look in details, IMRT versus 3D, cardiac deaths were much improved by the use of IMRT. And again here, because of the contraction of the intermediate dose away from the heart, most likely. And this is IMRT, and this is 3D. And the other deaths probably included some cardiac and others. They were not able to record or document the type, but they were improved by IMRT. However, the lung pulmonary deaths were not improved, and again, it's because of the dispersing of the low-dose region throughout the entire lung, most likely. Now, the cancer deaths were not improved as by IMRT. They were equivalent, again, because you are able to deliver the radiation there, but also because, as I said, most likely, this is my explanation, that distant metastasis, which is the most important cause of death in those patients, are not affected by technique. So this is important to realize, and does IMRT, if this is really working and is improving the toxicity in normal tissues, can we use it to increase the radiation dose and improve the local control? And do we know if local control, do we know if local control, it is, sorry, this is, oh. This is probably this is not the right slide, I'm sorry, but this is, I have here the overall survival. I don't know what came up. I have a slide here with local regional control, published also from MD Anderson, where they showed that more than 50.4 gray is associated with improvement of local control. You have to trust me, this is not here, probably those are superimposed graphs. However, the overall survival was not affected. And this is an indication that if you use more than 50.4 gray, you may be able to escalate the dose and deliver more, having more local regional control. So yes, it is possible, technically possible. However, we don't have currently any trial right now testing this concept of increasing the dose, again, because many people are keeping in mind the negative 9405 trial where high dose were associated with toxicity. So to conclude on this, radiation therapy with concurrent chemotherapy is the standard of care for locally advanced esophageal cancer. Neoadjuvant chemoradiation followed by surgery is superior to surgery alone in resectable esophageal cancer. We showed the meta-analysis, and we are familiar with the cross-trial data. Local regional control, however, with current regimen of CTRT is still inferior when surgery is added, and higher RT doses may be needed that could be used with the use of technology of IMRT, which are superior to 3D technique and could be used to increase radiation therapy doses and possibly local regional control. Thank you very much for your attention.
Thank you, Professor Fadi. Actually, very interesting presentation.